In this section, I think Martine asked me to speak about liver transplantation PSC, which I'm very happy to talk about. They're my two favourite topics. I'm very passionate about liver transplantation. Yeah, and rugby, yeah. And I'm very passionate about liver transplantation. I mean, the reason I went into hepatology was I remember as a young doctor working on the liver transplant unit in Edinburgh and seeing desperately sick people and seeing them a few months later and just transformed. And I'm yet to see an intervention that changes lives like it. And that is really why I remain so passionate about it. I think I've been asked to talk a little bit about liver transplantation. So I'm going to talk about, a bit around the background. How common is it for transplantation in the UK? When do we in the clinic think about referring someone? What's the process of getting onto a list? Talk a little bit about recurrent PSC after transplantation as well. And also happy to take any questions. So if I start off, so this is a graph, and this is people who are registered in the United Kingdom for liver transplantation over the year that they measure, which is sort of financial year from 2016 to 2017. And this shows you the conditions people are registered for across the UK. And you can see that the main reason that people are listed for a liver transplant is alcohol. And that makes sense. It is by far the most common cause of cirrhosis. And it's a very appropriate indication. People can get into trouble. We have very strict rules about who gets onto the list, and they do very well. The next common reason is hepatocellular cancer, which is a primary liver cancer that occurs in people who have cirrhosis of the liver. But you can see actually PSC is a common indication in the UK and is as common as non-alcoholic fatty liver disease. And other indications here, hepatitis B, hepatitis C, are actually less common. And that might surprise you, given it's a rare condition. But what actually does that tell us? It tells us we don't have a treatment bar liver transplantation, doesn't it? That sadly, a lot of people are requiring liver transplantation. It's a rare condition, but a common indication for transplantation. And this is some work from a unit here, a research fellow who's now working in Cambridge, Gwyl, where he looked at, again, people being listed for indications. You can see PBC, for which there are treatments, and over time better treatments, it's getting less common, whereas PSC is gradually increasing over time. So it's getting more common as an indication. Can I just ask the PBC? What is PBC? So it's a condition called primary biliary cholangitis. And it is also an autoimmune condition, we think. Some might dispute that. But it is an autoimmune condition, and it affects the microscopic bile ducts. And it is quite a different condition to PSC. And Palak has also a real interest in PBC, and I think it's fair to say treatment for PBC has really moved on over the last few years, and we have much better treatments for that, and therefore we are seeing less people requiring liver transplantation.
Is it more common, PBC, more common than PSC?
Yes, it is. It is, and yet we are doing less transplants.
Yeah, doesn't make any sense.
It does if you've got treatments, and you haven't got treatments.
Okay.
Yep.
There is a bit of not a crossover, but PSC and PBC, initially are they similar? Because Sean had a biopsy to determine whether he was PSC or PBC.
So they're very different conditions, but you're right, at the time of diagnosis, sometimes people can be not sure which one is which. So it's important to work out, but they are very, very different conditions to manage. So, it's just a bit of background, but what about making the decision? When do we decide to refer someone for a liver transplant? Now, the first thing to say, that should always be a joint decision that is made in the clinic with the patient. It's not just a decision that I or Palag or Fiona or anyone makes. It should be a joint decision that this is the right time. But of course, we're there to advise. We're consultants. We consult and we try and make that decision. We always try and err on referring early, because if you leave it too late, someone might not be fit enough for a liver transplant. PSC is unpredictable, all right? We're trying to make it more predictable by knowing more and more about the condition, but it remains an unpredictable condition and people can get sick quickly, and that always worries us. So there are certain things that raise concern for us and make us ask the question about whether someone should be referred for a transplant. Now, asking the question does not mean that someone will go onto the list. And if you are referred for transplant assessment, it could be that the team overall then say, look, we think this is a bit early, but that's okay. You've still found out a lot, etc., etc. But when do we think about asking the question? So, first thing is the easy one is when someone has got chronic liver disease, they have cirrhosis, and they are having problems related to cirrhosis, ascites, hepatic encephalopathy, variceal bleeds. So if they have real problems with their cirrhosis, in many respects, that's an easy decision for us to say, look, this is causing you problems. This means you are going to run into real problems with your liver, and we need to refer you for a liver transplant. We are, just to say that we are set by certain criteria nationally that you have to meet prior to being able to go onto the list. So you might have cirrhosis, but you might not be there yet as far as being referred. But as soon as someone has cirrhosis and is starting to run into problems with that, we really do start thinking about it. What other things make us think? Recurrent episodes of infection that are requiring regular episodes to hospital. Now that's a difficult one because lots of people get lots of cholangitis that we don't refer, but some others do. And I think, again, that's something that we discuss with the patient and we work together. But if these episodes are very serious, we don't feel we can get on top of these episodes easily, we do think about referring for transplantation. Next, if someone has got a fixed defect of very high bilirubin, we do start getting concerned. If someone, say, has an episode of cholangitis, they become jaundiced and it really doesn't improve, again, that worries us and makes us think about making that referral. And then there are the more nuanced cases where someone's got a lot of scarring, their spleens may be quite big, their bilirubin's quite high, that we start to think about it as well. But it's a hard decision. And, I've been a consultant. I know some people say I look quite young, but I've been a consultant for 10 years, and it's still a really, really hard decision. It keeps people like Palak and I awake at night, and it's not an easy thing to do. And we will bring it up, and we'll sometimes refer you too early, but I will always err on the side of caution, if possible. All right? What happens when we refer you for a liver transplant? Well, you go for an assessment process, and it's subtly different in all the transplant units, but here in Birmingham, it's predominantly an outpatient process. You come for a day, you have a vast number of tests in that day, and it's an all-over body MOT. What we want to see is that person fit enough to get through a big operation and not have any complications. And you then come back and you have a 2 to 3 day process where you meet all the team, physicians, surgeons, anaesthetists, specialist nurses, dietitians, physiotherapists, other people who've had transplants. And we learn lots about you and you learn lots about us. And then we have a meeting. And we have a meeting where we go through these two things again. There's a big group, big multidisciplinary team, and we decide, does this person need it? Do they fit the criteria? And are there any contraindications? And that brings me on to the next thing. transplantation is not something we can just offer to everyone. We have a limited number of livers, and therefore if it's going to be a procedure that is going to be not that successful for various reasons, maybe someone's got a bad heart, we have to try and use those livers wisely because we have a limited pool of livers within the United Kingdom. So it is something that we try and make good decisions, and we are governed by really quite strict criteria from the national kind of transplant board because of that limited number of organs. So, what then happens? Well, if you are accepted onto a liver transplant waiting list, you will then be seen quite regularly in your transplant clinic. We see people every 6 to 8 weeks, so it's quite onerous. And it's not that we do nothing during that time. I think we've moved on over the last few years. We now have really quite an intensive process in our waiting list clinic that involves physiotherapy and dietetics. We really try and get people as fit and as healthy as possible prior to that transplant. So we try and feed people up. Sounds terrible, doesn't it? And we try and get them doing exercise, and so they can get through that operation and recover as quickly as possible and have a successful outcome. Yes?
Just going to ask this question, because when I had my colectomy, there was an ERAS course before in enhanced recovery. Same kind of program?
Yeah. I mean, there are lots of different names for it. We call it prehabilitation. Some people call it feeding it up for Christmas. So I don't think it matters what it's called, but in essence, we are trying to get someone as strong and as healthy as possible to get through that operation. And sometimes we say, look, you're not quite there yet. We need to work with you for a bit before you go onto the list. And that happens too. Yes?
What about like mental health? I know a lot of doctors and surgeons that never go if someone's depressed and all that, so do you try and help them mentally as well?
So I mean, I think doctors in general aren't very good about addressing mental health, but it's a really, really important point. I think we underestimate the effect of having a long-term condition, of going through a transplant, etc. And we are now trying to address that more and more, and we are looking at how people are feeling as they're going through the assessment process, as they're waiting, and after their transplant. I mean, one thing I notice, and I know some of you here have had transplants, a lot of people have a big emotional dip after their transplant.
When I was after my transplant, I was lucky enough to have a good few years.
Yeah.
Then after that, there was a depression, a massive dip.
Yeah. And I think that's very common. I think people have coped, and then they have it, and then they have a high, and then they dip, and then they feel guilty about having a dip.
Yeah.
All these complicated things, and I think it's very common. I think it's something we need to address better.
As well, you judge yourself as well and say, oh man, there's so many other people out there.
Sure. No, I think it's very common, and I think it's something that we can do better on, and we are trying to work on that. So, on the waiting list, a lot of people ask me, how long do I wait? Well, it's how long is a piece of string. The average wait at the moment is about 5 months in the UK for a liver transplant. Some people get it done the day after. Some people wait 2 years. Some people have even waited 3 years. And I'm going to come on to talk about how that works. And then, of course, the transplant happens, and then hopefully successfully, and then we look after you in the clinic thereafter. Now, a few other things to talk about. A lot of people, understandably, when I'm talking to them about transplantation, want to know about, can this come back? And sadly, this condition can come back. Broadly, it comes back in, I would say, if this is a list of all the studies, you don't really need to see all these numbers, but in about 20% of people at 5 years. And we've been learning, I think Palak and I have written a lot about this over the last few years, about what type of things put people at risk of PSC coming back. So, for example, we know if you've had your colon removed prior to having the liver transplant, that you don't seem to get PSC back. All right? So that seems to be protective, or it's very rare. If you've had your colon removed, but you've had a pouch created, however, you do seem to get there is a risk of getting your PSC back. So there are things that we can predict this. Sadly, again, we don't have successful treatments about treating PSC or preventing it coming back. We know that it doesn't matter what type of immunosuppression you use. There's been talk about vancomycin, about all sorts of various things, but we don't have a real evidence base for treating recurrent PSC after transplantation. But it is there, it is something that we worry about, and there are certain people we know are at particular risk and certain people who we know that aren't at particular risk. And I think the main point I would put here is it's really important when people are making decisions about treating their inflammatory bowel disease, and particularly about choices around pouches, if you have got PSC, thinking about the future. And this is going off topic a little bit, but we know that pouches don't work so well, and that pouches are associated with more problems after transplant, including recurrent PSC. So it is something that's worth considering. As I said, there isn't really a link about the type of anti-rejection drugs we use in the type and whether people can get PSC back. So really for the next little bit, I just wanted to move on to talk about what is a new national offering scheme and how people get offered livers, because I think this caused a lot of angst, didn't it, Martine, when this came in?
Yeah.
And has been running now. Year and a bit, isn't it? It was a kind of sort of springtime 2017. That'd be right. Yeah, springtime. So, not been going on that long, and I was very involved in trying to put this scheme together. So, basically, it was to develop a set of rules to offer livers to a named patient, and this is for people waiting for a liver transplant. We call the elective waiting list. There's a super urgent category for people who are particularly sick, but that's a very small number and very rare. But most people are on something called the elective waiting list. And you may or may not be aware that there are two different types of ways people donate, all right, in the UK, called donation after brain death and donation after circulatory death. So if someone is pronounced brain dead on, for example, an intensive care, then a retrieval team will go out and after, obviously all agreement of the family, they will remove the organs and they will be transplanted to someone else. And that's really a very controlled situation. If, however, there's a situation where someone is going to die and the family again and everyone has agreed, but they are not pronounced brain dead, there will be, the patient will die. The team then have to wait a certain amount of time and then they can go and take the organs. Now, that is a situation where the organ itself has been starved of oxygen for a little bit longer, and therefore the reason I tell you the differences is that the ones after circulatory death, the DCDs, are higher risk organs. They are organs that have more issues, and also we've got to get them from that centre to our centre more quickly, and therefore they weren't included in this scheme because they are a more complicated group of organs. I say this about them, but 30% of the patients who get transplants get them here, and they have saved hundreds of lives. So although it might sound a little bit negative what I was saying about them, there's been a massive success, the introduction of that programme since 2010. But anyway, this scheme is only for DBD organs. So the previous scheme, and there are 7 transplant centres in the UK, 2 in London, Royal Free, and King's. There's Cambridge, there's Birmingham, Leeds, Newcastle, and Edinburgh. And they're very different sized units. So if King's and Birmingham are the two largest units, we transplant nearly 200 people a year, but for example, Newcastle transplants about 25 people a year. So there are real differences between those units. And the previous scheme, everyone had a zone. And we retrieved organs from that zone. We bring them in. And the way the decision was made was the team would look down the list, they'd have an organ, and they'd make a decision which patient went to, depending broadly on who needed it the most. But of course, that wasn't felt to be hugely fair, because it might be that someone up in Newcastle is getting a transplant, and their list is quite small, and their need might be a lot less than perhaps a person in Birmingham or a person in King's. So it was felt that moving to a national scheme would mean that the person with the greatest clinical need would get that transplant first. And that was the purpose of moving to the new scheme. So previously we had this local scheme. Surgeon would have a list, organ would come in, and they'd be like, right, boop, and it was like that. So we've moved to a slightly more sophisticated scheme, but it is complex. So we collect 21 details about the person receiving a transplant, all right? And we also collect 7 details about the organ that potentially is going to go into it. So it's 28 factors go into this equation. Now, this goes into a very clever computer, all right? And this computer calculates a benefit score. And what is the benefit score? Well, it's measuring the difference, okay, between what happens if you didn't have a transplant, so your survival on the waiting list, all right? The survival on the waiting list, and what happens if you did have a transplant, okay? So that's basically what the system is doing, utilizing these 28 factors. And it then produces a list of, I think it's 5 potential recipients, and the centres are called and said, right, your patient has an offer. Do you say yes or no? And that is now what has been happening for about a year and a half. What have we seen so far? We have seen that there has been a halving in the number of people dying on the waiting list in the UK. So that is a really good thing. There's been no change in survival at 3 months. I think there was a concern that we were going to be transplanting sicker people, and would that mean that maybe outcomes would drop, but there hasn't been a change. But I'm sure that this system will need a number of tweaks over time, I have no doubt. Yes?
So if I understand, does that mean that there could be a brain-dead donor in, say, Cornwall?
Yeah.
And it matches with a recipient up in Edinburgh?
Yeah.
So there must be, because of that, a longer transportation time.
Yep.
So I'm guessing there was, I don't know if it was in the UK, but there was the first drone delivery of a transplanted organ, I think 2 weeks ago. So has this system been created with that kind of thing in mind? Because obviously then you're not worried about traffic strands and things like that.
So we don't have lots of drones, but you are right. You are right. So a big concern was, gosh, previously it's been moved around the UK. How are we going to deal with these logistics? But I mean, having worked in Scotland, you can imagine if there was a donation up in Inverness and it has to get, that was often flown to Edinburgh, for example. And the logistics have got more complicated, and the organ is outside the body for a little bit longer, but actually not that much longer. And the other thing that's come in transplantation over the last few years is machine perfusion. Some of you may have heard about that. And that is revolutionizing it. We can now put livers on a machine. There was one a few days ago, was on the machine for 23 hours. So actually logistics is getting easier, because when you can put it on a machine and stick it on a shelf for a while, let the surgeon have a night's sleep, get up, that makes everything a bit easier rather than the frantic mayhem that transplantation is normally. So I think machine perfusion is probably going to solve all logistical issues. Yes.
3D livers, 3D print livers and all that.
Yeah. So they don't. Yes, that hasn't worked yet.
No.
We have to stick with human ones at present. Yes.
What about living donors?
So living donors. Okay. So we do have a living donor program in the UK. We do very few. We do very few. Why is that? It's partly because this program is so successful. We do a lot where mum and dad donate to their child. But because it's not a common thing in the UK, there aren't many mum and dads who'd accept it from their children, you know, if they're grown up. All right? And therefore, it's not a very big program. There are parts of the world where it is the only program because it's culturally unacceptable to accept it from someone who's died. So, for example, in Seoul, in South Korea, which is, I would say, the world-leading centre for living-related, they've just done their 5,000 living-related liver transplant. So it's a very common procedure in other parts of the world. It's not so common in the UK.
Do you do it up here?
Up? Yeah, we do, yes.
Can you just explain what that is? Because I don't know what that is.
So you obviously can't take the whole liver out of someone, otherwise they die. That's bad. It then depends who are you giving your bit to. If you're giving it to a small child, you can get away with giving a smaller bit, all right?
Is that based on the fact that if you take a part of a liver that's well,
Yeah.
it will regenerate itself?
Exactly. Yeah, exactly.
So you can afford
Yes.
to take a bit
Yes.
off a liver that's
Yes.
doing well.
Yes.
So in that bit you then would then transplant into, say, the child.
Yeah, but we do adult to adult as well.
And that that bit of transplanted liver
Yeah.
would then grow?
So it does grow to some extent. It does grow. It is often a difficult decision about, you know, is the lobe that you're taking out enough, A, for the person, but also what you're leaving, is that enough for the person? So you can imagine it's a very involved workup. But no, living related is a possibility, but we don't do huge amounts in the UK. I'm not sure that's probably worth talking about, but I think that's probably enough for now. But I mean, suffice to say, I've just kind of run through, you know, why we, around transplantation PSC, why do we think about referring people for it? Outcomes are really, really good. People do really, really well. It is a life-changing procedure. Recurrent PSC, however, sadly is a reality. For some people get it back and it's not a big issue, but there is a small proportion where it really is a big issue. And then I've just spoken a little bit about the new scheme. I think it's still early days, but the early data is encouraging. Okay, so happy to take any questions. Yes?
I know you've asked about drugs for livers, but one of the things that's always in my head is how the patients get to the place where they're being transplanted.
Yeah.
We're in the middle of nowhere.
Uh-huh. So I think people always worry about this, but actually there's more time than you think. It's a bit like when your wife's pregnant. There's more time to get to the labour ward than you imagine. It's not like in the movies. So actually, because often when we're finding out about the donor from the donor hospital, we're often calling people in, not when we've just got the livers just arrived. It's actually a very early point, and quite a substantial number of people who are called in, the transplant doesn't happen for all sorts of reasons, and we always warn people about that. But getting across is we can always find a way. Yeah. Yes. Yeah.
What about the condition of the liver that's being donated, if you like, in organ donation? I'm slightly older than most, and my liver has been subject to a certain amount of misuse, I'm sure.
Yeah.
So, how do you check that? I mean, is my liver too old?
So no, we use lots of chronologically gifted livers. So no, we do use lots of livers like that. But we assess it. As you can imagine, we assess the liver in all sorts of ways. What has the person died of? Have there been any particular risks? et cetera, et cetera. And we know from experience, 20 years of experience, what livers are good, and we are constantly pushing the boundaries. But, and I do say it's a but, there is always a slight risk in receiving a liver transplant, of course. You're receiving a liver from someone, and there might be something that we don't know about. But those risks actually are really tiny compared to the benefits from liver transplantation. Yep. Yeah.
So if you were, say, on the liver transplant list and you were near the top and considered for a liver that became available,
Yeah.
do you have to be checked for compatibility, I would say? Because presumably you could be number one on the list, but you might not be compatible necessarily to the liver that's being donated.
So the compatibility for liver transplantation is quite straightforward. It's just blood group compatibility. Yeah. So it's very different to kidneys, much more complicated, but the liver is a very immunotolerant organ, and therefore it's just blood group. Yeah. So Martine, did you want to ask?
Yes, please. Are you able to tell us anything about this trial that might be happening for cholangiocarcinoma and PSC?
Yes. So you'll be aware that sadly there's a small proportion of people with PSC who get a tumour of their bile ducts, cholangiocarcinoma, and treatments for that have not been very successful, and currently it's not allowed as an indication for transplantation if you have PSC and a cholangiocarcinoma. However, there have been studies from around the world where people have tried to transplant people with that mixture of conditions, and actually they've had reasonable outcomes, but with a very, very careful patient selection. So in the UK, we are working up what's called the service evaluation to try and do the same thing. And that's currently going through the Liver Advisory Group, which I know that you're kind of involved with, Martine. And so hopefully, I can't say when, but hopefully over time, that should be something that we can offer. Now, I imagine it'll be fairly based on a protocol that was developed over in the Mayo Clinic in the United States. So it's a very select group of people who are going to have certain oncological, so cancer therapies as well, pre and after the transplant. So it's going to be a big undertaking, but at least it's going to be a possibility.
Excellent. That's
Yeah, no, I think it'll come, yeah.
And even if it's very strict criteria to go on the trial, I think there was talk of maybe fast-tracking how quickly you get the liver for it as well.
Yeah.
I don't know if any of that's definite.
So I mean that obviously will be an important thing about how do you because obviously the need, these factors won't pick how much that person needs it. So they'll need some bonus points so they get done quickly. So that will be part of that protocol. Yeah. Yeah.
Thank you.
Okay. Yes.
It's not a question, just a comment, just to give a bit of hope really to people who are going through the transplant procedure. I had a transplant 15 and a half years ago now, and for me it's been a fantastic success. I was told after my transplant I would only live a few months without it. That's 15 and a half years ago, and since then, I've been given a new life. It's been absolutely fantastic. I certainly don't take anything for granted for the future, but up to now it's been brilliant, and I'm just so grateful for everything that's been done for me.
Great. Yeah, that's great. That's great. And I think another question I commonly get asked, I'm sure, Paolo, is how long will the transplant last? And I always say, I don't know. I mean, one of the clinics I run is for young people who've had transplants in childhood or as babies. So I've got people who are 30 who were transplanted when they were 1. And they asked me how long it lasts. I said, I don't know, you seem all right at the moment. So, yep. So do we want to move on? I don't know. Yes?
I've had a liver transplant, but I still get little niggles and pains.
Yes.
That's fine. That was 7 years ago.
So that's a really common question. It's completely normal. You have a massive war wound here with lots of scar tissue underneath it, and niggles and pains are very, very common. Yeah.
Always worry.
No, not at all, not at all. So I think we're moving on to somebody who's actually had a transplant. Yeah.